Good morning, everybody. Welcome back. Today we'll talk about, I believe it's very important topic for everyone is dealing with critically ill patient. How to approach a patient with respiratory distress and hypoxia by ultrasound, critical care ultrasound, a step-by-step approach. These guidelines are concerning with a patient with respiratory distress and hypoxia. So ABG is mandatory before applying these guidelines. To exclude two common causes of respiratory distress without hypoxia, which is metabolic acidosis and the cosmal respiration, and non-hypoxic respiratory alkalosis as a cause of respiratory distress. In this situation, you will see the patient tachypnic, hyperventilating, but is not hypoxic. Don't apply guidelines in this type of patient. First, look at the inferior vena cava. Usually, in my protocols, I need to be step-by-step approach. I need to organize myself before touching the patient by probe. So, first, please go to the inferior vena cava. If you see the inferior vena cava is narrow, collapsing, is flat inferior vena cava, start to think about infection, sepsis, distributive shock. This inferior vena cava is narrow, totally collapsing. If the patient is gasping for breath and hypoxic, please, second step, probe, phase array probe on the chest, and look for pneumonia or sepsis with ARDS. First, pneumonia, narrow, collapsing inferior vena cava, and distressed patient. Look for consolidation, hepatization of the lung with mobile airbronchogram. This bright echogenic cords, small cords, is called airbronchogram. If you see this airbronchogram moving, it is dynamic airbronchogram, typical of pneumonia. What else? I need to see you. This is the lung. This is the normal lung. A lines, transverse lines all over. This is the pneumonic lung. It is similar like organs. This is a spleen or liver. It will become like spleen or liver. Hepatization. This is echogenic cord is the diaphragm. This is the spleen, and this is the pneumonic lung. You see here, it is became an organ, not a lines. Before leaving this point, I need to explain what's the difference between collapse and consolidation. You see here, this is the beauty airbronchogram, moving, mobile with breathing, but in collapse, in this patient with collapse due to malignancy, you see metastasis here in the liver, you will not see any airbronchogram, and if you see it, it will be static, not moving, because already bronchi is blocked and no air going down. So, narrow, collapsing inferior cava, and distressed hypoxic patient, first look for the pneumonia, and you know now how to look for. Second, ARDS. Please, it is very common in our job, this ARDS. Remember to look for this good three: heterogeneous B-line, B-line with A-line at the same lung region, subpleural consolidation, and sick pleura. Let us clarify this point. Narrow, collapsing inferior vena cava, and distressed patient, and I am looking now for ARDS. You see this region of the lung in distressed patient. You see B-line alternate with A-line. This B-line, and at the same lung region, A-line. If you see this A and B-line at the same lung region, please, picture is going with ARDS, not going with cardiogenic pulmonary edema. What else? This is the B-line, dense B-line coming from the pleura here, like a curtain. If you see here, subpleural, you will see hypoechoic region, raised edge, dirty hypoechoic region below the pleura, which is called subpleural consolidation. It is a unique for ARDS and interstitial pneumonia. You see, look for this dirty hypoechoic area, which is called subpleural consolidation. It's going with acute lung injury. What else? You see here with high frequency probe, it appears very, very clear, raised edge, dirty hypoechoic area below the pleural line. What else? Sick pleura. So, narrow collapsing inferior vena cava, distressed hypoxic patient, and you look for the lung, there is sick pleura, dirty subpleural consolidation, and heterogeneous B-line, that means A and B-line at the same lung region. You are talking about non-cardiogenic pulmonary edema, you are talking about acute lung injury. So, in the first stage in our protocol, look for inferior vena cava. If it's narrow, collapsing inferior vena cava, you are talking about infection, sepsis, distributive shock. Look for pneumonia, as we see, and look for signs of acute lung injury, of sepsis, and ARDS. Okay? If the inferior vena cava is fat and non-collapsing, like this elephant inferior vena cava, and your patient is severely distressed and hypoxic, please look at the lung. As you see here, you are targeted. Look at B-lines. If you see homogenous B-line with thin pleura, like this patient, thin pleura, homogenous B-line, and no A-line in the field, and no subpleural consolidation, you are talking about cardiogenic pulmonary edema. I need to clarify this point more. As you see here, this is cardiogenic pulmonary edema with thin pleural line and no subpleural consolidation and clean pleura, and here you see subpleural consolidation and sick pleura. This is acute lung injury, this is cardiogenic pulmonary edema. Second step, look at the heart for cardiogenic pulmonary edema, and you need to exclude the heart here. All causes of the heart you need to search for. This myopathy, or this mitral regurg. So, if the inferior vena cava is elephant, is dilated, non-collapsing, look at the lung. If you see thin pleura with cardiogenic pulmonary edema, with homogeneous B-line, go to the heart to know the cause of the cardiac, the cardiac cause of this cardiogenic pulmonary edema. If cardiogenic pulmonary edema, in this point, it's very important. If you diagnose cardiogenic pulmonary edema, I need you please check the lung for precipitating pneumonia. Remember, it is guidelines, but there is actual practices, which is usually actual patient, which usually has mixed pathology. What else? If the inferior vena cava is elephant, is dilated and non-collapsing, and you went to the lung, no pulmonary edema, pulmonary edema, but lung ultrasound is normal with predominant A-line profile and good sliding. This patient has respiratory distress and dilated non-collapsing inferior vena cava and with normal lung ultrasound. If the inferior vena cava is dilated non-collapsing and the lung ultrasound is normal with predominant A-line profile and good sliding, like this patient, This patient is gasping for breath, hypoxic with dilated non-collapsing inferior vena cava and normal air profile and normal sliding. And the normal sliding. In this situation, please, it is a real danger here. Attention, here with severe dyspnea and hypoxia, dilated non-collapsing inferior vena cava with normal auscultation and normal lung ultrasound, here I start seriously to think of pulmonary embolism. And I need to look for signs of pulmonary embolism in the heart, which is, as you see here, ballooning right side, shifting of all septum, interatrial and interventricular septum to the left side, compressing the left side. What else? D shape of the left ventricle because of pressure on the septum. And as you see here, during diastole, no more pressure on the septum, but the pressure more in the systole, which is pressure overload of the pulmonary embolism. What else? Maconell signs. You will see the apex is moving more than the free wall of the right ventricle. This is the Maconell signs. It's going with pulmonary embolism. If you find dilated, non-collapsing inferior vena cava with good A-line profile of the lung, you will go to the heart for signs of pulmonary embolism. Ballooning of the right side, Maconell signs, and D-shaped left ventricle. Please complete your study by collapsibility test of the femoral vein. As you see here, with compression, there is thrombus inside the femoral vein. As you see here, the blood all around the thrombus here in the femoral vein. So, if the inferior vena, again and again, if the inferior vena cava is dilated, non-collapsing, you will go to the lung. If you find cardiogenic pulmonary edema profile, which is seen pleura with homogenous B-lines, go to the heart to know the cause of cardiac lesion which lead to cardiogenic pulmonary edema. If the inferior vena cava is dilated, non-collapsing, and you went to the lung, you find the lung completely normal, you should think about pulmonary embolism and look for signs of pulmonary embolism in heart. Third, if you find inferior vena cava is dilated, non-collapsing, and there is A-line profiles but not good sliding like pulmonary embolism, bad sliding, you will see the shimmering movement of the pleura very poor. Like this patient, you see there is a sliding, but it is bad sliding. There is sliding and some B-lines here, but it is bad sliding. In this situation, please look to the heart for signs of tricuspid regurg and pulmonary hypertension. This is a tricuspid regurg and the hypertrophied right ventricle. This is the signal of tricuspid regurg denoting pulmonary hypertension. It is obstructive lung disease and the corpulmonale. Because in obstructive lung disease, there is displacement of the diaphragm and the displacement downward, and the diaphragm will be flat. So the chest movement is very poor, it's very sluggish. Because of that, you will see the shimmering movement of the pleura and the sliding is very bad in the lung. So inferior vena cava is dilated, non-collapsing. With bad sliding, go to the heart, and if you find tricuspid regurg, pulmonary hypertension, it is obstructive lung disease and the corpulmonale. If you find A-line with absence of lung sliding and the lung point, here, as you see here, no sliding. It's only humping movement, up and down movement of the pleura because of respiratory distress and the movement of the chest wall. It's not sliding, it's humping movement, up and down movement of the pleura. You see here with Emma mood, no more seizure appearance, barcode sign. If you see here, this amazing picture, no sliding here, but sliding here, no sliding, sliding. This is the lung point, no sliding and sliding here. Next video is amazing really, because sometimes you will see area of non-sliding and you will see the lung point as transmitted pulsation, lung pulse. If you see lung pulse in close proximity to non-sliding pleura, you can consider it as a lung point. Look for this amazing video for pneumothorax. Humping movement, no sliding. This is the rib, this is the rib shadow, this is the pleura. As you see here, no sliding, only up and down movement, no sliding. Start to appear here. The lung point is transmitted pulsation here. Transmitted pulsation. It's amazing video really. You can see lung point as transmitted pulsation here in this patient. It is pneumothorax. So, if to sum up, if the inferior vena cava is narrow and collapsing, please look for signs of pneumonia or ARDS in the lung. If the inferior vena cava is dilated, non-collapsing, go to the lung. Cardiogenic pulmonary edema profile, seen pleura with dense B-lines, homogenous B-lines, go to the heart to look for the cause. If it is normal lung scan with good sliding, you are thinking about pulmonary embolism and check for DVT. If it is bad sliding with distended non-collapsing inferior vena cava and bad sliding, go to the heart to look for tricuspid regurg and pulmonary hypertension. It is a corpulmonale. At the end, if no sliding and lung pulse and absence of seizure barcode sign, so it is pneumothorax. At the end, exclude massive pulmonary effusion as a cause of dyspnea. This is pulmonary effusion. So, step 1, look in the inferior vena cava for diameter and collapsibility. Step 2, if narrow and markedly collapsible, look for chest infection and sepsis, so probe on the chest and look for consolidation and the airbronchogram, it's lobar pneumonia. Heterogeneous B-line with area of A-line, sick pleura more than 2 mm, as well as subpleural consolidation, it's more with viral pneumonia and the ARDS, acute lung injury. If inferior vena cava is full and non-collapsing, probe on the chest. If there is homogenous B-lines, seen pleura, as well as absence of subpleural consolidation, probe on the heart to look for all causes of cardiogenic pulmonary edema, myopathy, valvular, ischemic, diastolic dysfunction, and tamponade. Step 4, if lung scan reveal absence of significant B-line, predominance of A-lines, if good sliding, look for dilated right ventricle and the Maconell signs of pulmonary embolism and the comparison test for DVT. Step 5, if A-line and bad sliding and seizure in EMA mode, examine properly for obstructive lung disease and look for cardiac signs of corpulmonale. If A-line and the absence of sliding and seizure, absence of seizure and sliding, carefully look for lung point of pneumothorax. Step 7, look for massive pleural effusion explaining the dyspnea. The next is the most important step in our protocol. Step 8, again and again. These are guidelines, but you have actual patient usually with mixed pathology. So, if you diagnose cardiogenic pulmonary edema, please look for the common practical precipitating factor, which is pneumonia. And if you find the pneumonia, look at the heart for stress myopathy and the other lesions. Let us see. Really, I applied this protocol for hundreds of cases, and I had a lot of cases. But now I select a few cases to explain this protocol. 17-year-old patient, known case of renal failure on dialysis, hypertension, on mechanical ventilation, and difficult to wean because of post-extubation flash pulmonary edema. This is the X-ray. This is the catheter for dialysis, and white chest. We start critical care ultrasound for respiratory distress. Inferior vena cava is full, non-distensible. We put the probe in the lung, seen pleura, homogenous B-line, going with cardiogenic pulmonary edema. Look to the heart, parasternal long axis view, distended left atrium, contractility are talking about 40%, said 40% is effusion here. This is for a chamber view, ballooning left atrium, and contractility here, and it seemed to be better than long axis view, about 45%. You see here aortic regurg, moderate aortic regurg, moderate mitral regurg. So, in the presence of moderate aortic regurg and mitral regurg, with this ejection fraction, I will consider it's too much poor, this ejection fraction for a regurg lesion, with a regurg lesion. Here, restrictive pattern of the diastolic dysfunction denoting congestion, going with cardiogenic pulmonary edema. This is very tall E wave compared to A wave. So, please, before taking the probe of the chest, always, in case of cardiogenic pulmonary edema, assess the lung properly for two things. Bad pleural effusion, especially right side, which is common with heart failure, pneumonia precipitating the cardiogenic edema. In this patient, really this was the situation in the basis of the lung. Complete hepatizations of basis of the lung. Complete hepatization. So pneumonia here was a real factor in the patient respiratory distress. Again, all steps leading to the cardiogenic pulmonary edema, but there is a bad pneumonia precipitating the event. It is the truth, my dear. It is the real medicine. It is a mixed pathology. Case 2. I was called to see this 78 years old male patient admitted in the medical ward 10 days back because of recurrent attack of disturbed conscious level, suspected to be a non-convulsive seizure disorder. Today he developed the shortness of breath. I saw the patient, he was tachypneic, 35 feet per minute, O2 saturation 96 on 8 liter, and hemodynamically stable. Scenario is going with aspiration, this repeated loss of consciousness. Starts the protocol. Fat, non-collapsing effusion vena cava, go to the lung, B-Lines all over. Go to the heart. It is very poor contraction, almost visual 10%, parasternal long axis view. Mitral regurg with very poor contraction in for chamber view. Tricuspid regurg. It is straightforward cardiogenic pulmonary edema, despite the situation is going with aspiration clinically. But in cardiogenic pulmonary edema, before leaving the patient, please check for pleural effusion and the precipitating pneumonia. Here is the patient pleura full of fluids, and you see here a lot of fluids in the pleura. Probably it will need therapeutic aspiration and atelectasis because heart failure is a very common cause of pleural effusion, massive pleural effusion. As you see here, you should always think about mixed pathology, and thank you for watching, and I see you in another protocols, inshallah.